Okay, so today we have a very special session. As you know that ESBICM is expanding the critical care network, the faculty network, and where very talented young minds and those who are working critical care, those who are very academically and clinically oriented, they come and present their sessions. And in this series, today we have Dr. Revathi Nair, who is MD DM in trauma critical care, and she is the assistant professor at present in the Institute of Dr. D.Y. Patil Medical College, Pune. And she had worked on a lecture which is very, very important. I think everybody should know regarding this, those who are working in intensive care, which is a checklist before the brain death certifications. And I am telling you that for the last 1 week, she is working hard on this lecture to make this lecture as a comprehensive presentation in which most of the things, almost 95 to 99% of the things are covered, which you should know essentially in the brain death certification or the organ donations, what are the prerequisites. And I've gone through this presentation and it's wonderful. And in spite of her being such a busy schedule, she has spared time for us to deliver this session. So I'm very thankful, Dr. Revati, and the whole viewers or those who will listen this session will be very, very thankful to you, and they will get. I'm very hopeful they will get benefited from this session. So those who are listening, because there is a little bit of glitch in the network as of now, even if the audio drops, we will try to edit it in the post production. So if there is a little bit of glitch in between, please bear with us. But I'm sure that the session is going to be very useful and enlightening for all those who are listening this. So thank you and welcome, Dr. Revathi, on the ICU channel by ESBICM. And now you can start your session the way you are comfortable.
Thank you so much, sir. Thank you for the wonderful introduction, first of all, and for the chance. I'm very grateful. I've been following you for a long time, and your insights have been guiding most of our clinical care practices for a long time. Um, so, my topic for today, sir has very gracefully asked me to present this topic, which I have been working on for a time, for a month or so. So, this is about checklist before brain death certification, which is an important forte for all critical care intensivists because we actually mechanically do everything that we need to before and after brain death certification, but we don't have a established flow for it. So I have tried to bring together, consolidate the entire flow, and that's what I'll try to present here. Shall I go ahead, sir?
Yeah, sure, sure.
Yeah. So this is about checklist before brain death certification. Now let's just understand what is the legal framework that brain death certification works on. So India, brain death certification, you can't have the same size fit all policy. So it is not the same framework that follows throughout the world. India follows its own framework, which is given by the THOA or THOTA guidelines, that is the Transplantation of Human Organ and Tissue Act, which was 2008 with the amendment in 2014 and 18. So according to the THOA THOTA Act, it has been clearly stated that brain death does equate with death of a person. So it might be difficult to come to terms with brain death per se, because cardiac death shows everything on the monitor clear as day, and it becomes easy to accept that the death has occurred. But brain death is not like that, because the monitor shows picture perfect vitals at times, but the patient is gone. So it might be difficult for the intensivist also to bring the family to terms with it, which is the reason why brain death cannot be certified by an intensivist alone. You need an entire group of people to come together to perform a few tests and to confirm that the patient is actually brain dead, and then bring it to the family. So there are two different things. One is brain death certification and one is organ donation. Both do not amount to the same thing. Certifying brain death does not mean that the patient's family has given consent for organ donation. In India, certification of brain death occurs once a form called Form 10 is filled and signed by all the dignitaries, all the authorities. Once that is done, if the family consents to organ donation, then that is a separate form, which is a Form 8. which is filled and signed consent by the family, only then will the donation consent happen. So brain death is different and organ donation is different. This is an important distinction to understand. So brain death equates to brainstem death, which also equates to clinical death. And it should be certified not by an individual doctor, but by a board of medical experts because it is a tricky thing to certify. As an intensivist, when will you suspect brain death? So you need three criteria to be fulfilled at the outset, which is a Glasgow coma score of less than 4 in the background of a catastrophic brain injury or unsalvageable radiological findings and with no confounders. So if these three criteria are fulfilled, then you can suspect that the patient is brain dead. So the clinical preconditions, as I told you, first is an irreversible cause of coma established. I will tell you what irreversible means later. Second and most important is neuroimaging, which is consistent with catastrophic brain injury. And third is that you excluded all confounding factors. If you satisfy all these criteria, if your patient satisfies all these criteria, then you can suspect that the patient is brain dead. All this should be happening in the background of absolute hemodynamic stability, even if you are using vasopressors. So, what I meant by looking at suggestive radiology is something like this. So, these are a few patients from my institute. You can see the scan on the left hand side. This is what we typically call a tight brain. So, there is the cisterns are effaced, the ventricles are closed, and there is no place for the brain to expand. So, this is a tight brain. And this patient, if he's showing a GCS of 3 with all the confounders excluded, he most likely might be brain dead. Look at
Okay.
the scan at the right. Yes.
Just a question, Revati, that two things. One, you have very rightly said that brain dead certification is different from organ donation. So means if a person can be brain dead by the whatever apnea test we are going to discuss, it is not mandatory to go for organ donation. It just we are prognosticating the family that now there is a irreversible damage and the recovery
Right,
chances are gone,
right,
100%.
sir.
That's the. And secondly, regarding whether this radiological imaging is mandatory for declaring a brain dead, without imaging can we go ahead?
No, sir. You need some clear-cut basis, grounds on which you will establish the brain death diagnosis. So these three are absolutely non-negotiable. A GCS less than 3, absence of confounding factors, and a catastrophic CT. These three are non-negotiable.
So suppose what happens, a patient suffered a cardiac arrest in the ER or outside on the road and then went to our ER and then we ventilated and everything is done.
Hmm.
Suppose now there is no sign of brainstem as of now. So in
Hmm.
that case also we need to do an imaging, or post cardiac arrest also we need to do a brain imaging before declaration.
Definitely, sir, you might need to do because you don't know the time for which the patient has been anoxic or hypoxic, and there is every chance that he might recover, even though immediately post-ROSC he might not be showing any signs of life. So it is always better for your own safety that you get a scan done.
But means in the guidelines you need to have an imaging. There is no doubt about it.
No doubt about it.
Okay, thank you.
So the scan on the left would typically be called a Marshall grade 6 CT scan, while the scan on the right is a grade 5 decompressed scan. But it is again fully effaced and there is no room for the brain to breathe here. So both these scans in the background of a GCS of 3 with the absence of confounding factors, it would mean that the patient is probably brain dead and you can evaluate further. But at the same time, if you go ahead and do this, the left is a transcranial Doppler window. If you had a scan like the one previously shown and your transcranial Doppler looks something like this, you definitely have to think twice because this shows that there may be signs of life. Also, if an ONSD is zero point 0.5 or lower, then also you need to think twice.
Revati, just for the audience, those who are listening, they may not have idea about the transcranial Doppler and this. Can you elaborate? So what I can make it that in the transcranial Doppler, it is still showing some flow in the cerebral vessels, which you are
Yes,
looking. And
exactly.
this is the scan imaging of the eye. So can you little bit explain them just in simple terms? What does this mean? That
Definitely.
though the imaging is showing that this patient is brain dead, But these two modalities, the optic nerve sheath
Yes.
diameter and the transcranial Doppler, is
Yes.
showing something different.
Something different. So the picture with an optic nerve sheath diameter and the transcranial Doppler is very different, and it should make you think twice. So here what is happening is transcranial Doppler is you create a small window using the ultrasound probe through the thinnest part of the skull bone, which is usually a transtemporal window just next to the tragus.
Mm.
And you look at the circle of Willis. The closest structure that you'll be able to see is the middle cerebral artery. Now, if the brain is so tight or so edematous that there is no flow occurring, ideally you should not be able to see a pulsatile flow like you can see in this. So, if you can see a pulsatile flow and the diastole is not touching the baseline, it means that the brain is still receiving blood and that the brain has signs of activity. On the contrary, if you see an absent or reversed diastolic flow, then it points more towards the brain death.
Mm.
Uh,
Okay.
that is about transcranial Doppler. Optic nerve sheath diameter is a surrogate marker of an ICP, raise in ICP, though it might have many confounding factors, but it is considered that an optic nerve sheath diameter of less than 0.55 centimeters in adults is normal. So
Okay.
if you have a zero point 0.4 centimeter reading, it should raise suspicion in your mind.
Okay.
So, if your radiology is suggestive of catastrophic brain injury, but ultrasound shows otherwise, you please stop and think twice. In the background of a GCS of 3 and the presence of catastrophic brain injury on CT scan, you need to make sure that you have certain mandatory preconditions also satisfied, because in the ICU, sometimes just correction of sugars or correction of sodium may make the GCS improve by leaps and bounds. So these are confounders that you need to eliminate before you can evaluate the patient for brain death. So what are these confounders precisely? Um, one is PCO2, one is PaO2, sugars, sodium, and residual or paralytic drugs. So CO2 should be 35 to 45 millimeter of mercury usually. PaO2 should be more than 60 millimeters of mercury. Sugars of 80 to 200 milligram per deciliter. Serum sodium of 135 to 155 milliequivalent per liter. And the absence of any residual sedative or paralytic drug. This is most important when it comes to our ICU setting.
So, Revati, in this, I would like to ask that suppose a patient is of COPD, and in
Hmm.
this COPD patient, if the baseline PCO2 is somewhere around 50, 55, or 60, so then how will bring it down? Do we mandatory have to bring it down to 35 or 45 in COPD
No,
patients?
sir. No, sir. So the 35 to 45 range is because when we go for an apnea test, we need the CO2 to rise enough to trigger a breath.
Hmm.
So in COPD patients, the trigger set might already be high. So we will look at the pH instead. We will go for a normal pH
Hmm.
level. And even if we start with a higher baseline of 45 or 50 or so, when we do our apnea test, the absolute rise of 20 mmHg will be what will be more important for us.
Hmm.
So this
Okay,
is
so
35 to
means
45.
if suppose at PCO2 of 55 your pH is somewhere around 7.35, that's okay. But from
That's okay.
55 in apnea, the PCO2 should rise from 65, 75. Means
Yeah,
uh,
at least
20
to
should,
75.
and
Yes,
it should
sir.
be more than 60 at least.
It should be more than 60. Absolute rise of at least 60, or the rise from baseline should be more than 20.
Why we have said this absolute should be around 60? Suppose we start with 35 and we 20 rise is 55. So
Hmm.
will we consider as in positive apnea or it should be our 60?
No, 55 won't be considered as positive apnea because 60 is usually considered a potent stimulus for stimulating a breath or initiating a breath. The respiratory center gets stimulated enough. So 55 may not be sufficient. That's why a 60 target is chosen for most patients.
Thank you. Thank you.
So just to drive in the point again and again, a GCS of 3 is a mandate in the absence of any sedative, opioid, or neuromuscular blocking agents. And we need to remember a washout rule. So washout rule is once you know the half-life of all the agents that you use commonly in your ICUs, ketamine, midazolam, propofol, thiopentone, it is important that you wash out the drug enough so that it is not in the system for long enough and it does not interfere with your GCS assessment. So we wait for at least 5 half-lives of the drug to pass before we can go ahead and test for brain death. So once these three prerequisites are fulfilled, we go for a clinical examination bedside. So this will not be a part of apnea testing, but this is for your own learning and for strengthening your own suspicion. So you can do a bedside clinical examination of the reflexes that we test for. So these are the brainstem reflexes. And if the patient is actually brain dead, or the patient is brainstem dead, then these reflexes should be absent. What are the reflexes? Pupillary light reflex, corneal conjunctival reflex, oculocephalic, that is a doll's eye reflex, oculovestibular, that is a cold caloric reflex, cuff and gag, and a motor response to pain. All of these should be absent. Bear in mind, please, that you won't do a doll's eye reflex if the patient has a cervical spine injury, and you won't do a cold caloric test if there is a tympanic membrane rupture. So one very important question that we need to address here is whether medical legal case is a contraindication for brain death certification. So as intensive care specialists, we all know that most of our cases are MLCs and they go ahead for brain death certification. So no, MLC is not a contraindication per se for brain death certification, provided you complete timely adequate documentation in these cases.
So just wanted to ask, like, what would happen to postmortem? Suppose now this patient needs to be sent to the PM. Obviously, the PM will be done. So in medical legal case, how will this postmortem thing will get managed?
Okay, so at some centers, the postmortem, the forensic team comes to the OT itself, and the postmortem is done at the retrieval table itself. At some centers, the body post retrieval is shifted for the postmortem. So depends on the hospital policy, whatever the hospital finds it comfortable with, or whatever is the SOP of the hospital according to
Okay,
that.
so what's the state policy or SOTO says that based on that, but PM is done in coordination with the retrieval team.
Coordination with the retrieval team.
And one thing I think I missed, I was not able to interrupt you, that washout time. Can you go back to the previous slide? This washout rule. So you said that more than 5 half-lives of the drug should be passed. So the commonest agent which we use is midazolam or fentanyl or etomidate. So approximate time, can you just give us an idea whether it should be 12 hours, 24 hours? Suppose a patient of road traffic accident came to the ER, you ventilated by giving the sedatives. Now, 2 hours
Yes.
later, you did a scan and everything, you find that no, this is not a salvageable patient. So, how much time we
Yes.
should wait from here for
So
these five
yes,
half lives?
so the most common drugs that we use are midazolam, propofol, thiopentone. Midazolam, thiopentone, they have a very long half-life also at times, so when given as an infusion. So it is better to wait 48 hours at least because the role of hypothermia and the role of other confounders further, delays the washout of these drugs. So it is always safer to wait for at least 48 hours before you go ahead.
Okay, okay, thank you.
Okay, so as we discussed, medical legal case is not a contraindication, and PM postmortem occurs according to the state organ transplant authority policy that is followed. So now, when you suspect brain death as an intensivist, now what do you do? What is your next step? Who will you inform next? What is the chain of command that you will follow? Who will declare the brain death? And what will your role be through all of this? This is what we are going to explore in a few slides. So coming to the chain of command, suppose you are an intensivist, you are working in the intensive care unit as a consultant. The chain of command will be you inform your higher authority, which would be your head of the department, and then the chain follows. So the medical superintendent will be informed through your ICU in charge, who will then coordinate with the hospital transplant team. Then a brain death certification board will be made. We will discuss what the certification board consists of. Then the apnea testing will follow, and the documents will be submitted to the zonal transplant coordination team. So the certification panel, which is formed after the MS is informed, is It consists of these four people per se. The first is the treating doctor. Second is an independent registered medical practitioner who is unrelated to the care of this patient. The third is a neurologist or neurosurgeon. The Toa Tota guidelines of 2014 allow that this neurologist or neurosurgeon, if he is absent, it can be replaced by an anesthesiologist also. And the fourth is a medical administrator. These four people together form the panel which will examine the potential brain dead person for certification of brain death. And the Form 10 will be filled, duly completed, and signed twice by these four people. So, your role as an intensivist will now switch from the diagnostician and the treating physician to the treating physician plus the facilitator. So now you are going to be helping with the apnea test logistics. You will ensure adequate reoxygenation. You will monitor hemodynamic stability throughout the process. And the patient is now your responsibility. So you will abort the test immediately if it becomes unsafe for the patient. And administratively, you will be looking after the documentation timings. Now, when the panel comes to you for testing for apnea, they will be looking at the brainstem reflexes as well at the same time. So, you need to be ready with all the things that will be needed for the brainstem reflex testing plus the apnea testing. So, make sure you have standard PPE, gloves, mask, gown, shoe covers if needed. Standard tracheal O2 insufflation catheter. At most of the centers, that is just a suction catheter attached to an oxygen tubing. This should be present for the apnea testing. A 50 cc syringe with ice cold water for the cold caloric test, a torch for pupillary light reflex, cotton whisk for conjunctival and corneal reflexes, a hammer for plantars, and on the monitor, make sure that respiratory impedance waveform is enabled. Now, when we talk about the tracheal O2 insufflation catheter, it is important that you make sure that the tracheal catheter diameter is less than 70% of the tracheal lumen. Because if the catheter occludes all of the lumen of the trachea, the patient is probably brain dead, so he won't be able to breathe out. So, all this air that is going in can cause a pneumothorax. So, this is very important. Now, what will your operational readiness be? How will you prepare the ICU? You have to remember that you are responsible for the environment and stability of the patient, not for the testing itself. So make sure that the environment is conducive to testing. Make sure that the equipments are working fine, a ventilator and pre-test ABG is ready, and the ABG parameters are within normal limits. Make sure that the hemodynamics are stable, that vasopressors or inotropes are running, and that they have adequate backup. The battery should not be running out, or the infusion should not be at their end. Make sure that you have turned off sedation, make double, triple sure, and make sure that you have documented the time when you switched off the sedation and paralytic agent. It is always best to have a recent lab data available. And family, it is according to the state policy, whether they can be present or not. Now, coming to the pre-apnea organ-specific management. For different organs, you might need to manage specifically. You might need some specific tests to be done when a specific organ is planned for retrieval. So, coming to the heart, if the heart is planned to be retrieved, you will definitely need a 12-lead ECG. You will need a 2D echocardiography, of which an image and video documentation is required at times. You will need cardiac enzymes done at baseline, which includes an NT-proBNP, and then you will need serial enzymes done as well. And if the patient is more than 40 years of age or at CAD risk, then a coronary angiography may be needed. Coming to the lungs, a chest X-ray is mandatory. Arterial blood gas is done within the last 2 to 3 hours of the apnea test. A sputum gram stain and culture should be sent, and report ideally should be present before the apnea test. And bronchoscopy needs to be done when the lung is planned. COVID-19 RT-PCR has been made mandatory since 2023 when the lung transplant is planned. Respiratory cultures, it is important that you send it as early as possible with the donor receiving antibiotics for at least 48 hours, which is continued into the recipient for at least 7 days post-op if you have an isolate on the culture. Coming to abdominal organ procurement, what is common for all three, kidney, liver, and pancreas, is an ultrasound. For all three, you might need a CT depending on if the team that procures the organ or the transplant team requires a CT. For kidney, you will need a blood urea level, serum creatinine level, urine analysis, and HTLV1 or biopsy. For liver, again, a biopsy may be needed, and LFTs are a must, along with coagulation and albumin. Coming to the pancreas, in labs, amylase lipase is a must, along with USG abdomen. So when you are screening the donor, what is mandatory is that you screen for HIV, HBS, and HCV. We will come to the conundrums regarding these later. Additionally, you might need to screen for cytomegalovirus, Epstein-Barr virus, and toxoplasma. Make sure that you collect undiluted samples because diluted sample may give false negative results. In biochemistry, what are the mandatory checking that you need to do is an ABG panel where you document a PaO2, PaCO2, pH, ideally within the last 2 hours of the apnea test. Sodium, potassium, calcium, ideally the same day values. A metabolic blood glucose, ideally within 1 hour of the apnea test. Renal and liver functions, and a toxicology screen is mandatory if there was any exposure to toxins. Coming to sepsis screening, it is important that you send all cultures as soon as possible and a viral screen, that is HIV, HBV, HCV, syphilis, malaria, and dengue. It is important that we also screen for donor-derived malignancies. What malignancies are acceptable and what are not, we will discuss further. And it is essential to assess how suitable the donor is, whether he is a standard donor or an expanded criteria donor. So how do we proceed with an apnea test? So apnea test, as we discussed earlier, is where you allow CO2 to rise to a level that can trigger a breath. Now, if the CO2 has risen far enough and it has not yet triggered a breath, it means that the brainstem is not able to respond to that stimulus. So the patient is brain dead. So how do you go about with the apnea test is that you pre-oxygenate the patient for a good 2 minutes with 100% oxygen. This is because we will be subjecting the patient to apnea for 8 to 10 minutes, and during this time we don't want the patient to desaturate or hemodynamically collapse. So pre-oxygenate. Following that, you disconnect the ventilator and only insufflate oxygen through a tracheal catheter at 6 liters per minute, and you observe for any spontaneous respiratory effort. That is how your apnea test proceeds. Now, how do you interpret an apnea test? Patient is disconnected and oxygen is going on. At this point of time, if you observe any respiratory effort, it means that you have to abort the test and the patient is not brain dead. That's the end of the story. If the patient's hemodynamics collapse or the SpO2 drops, again abort the test because you are responsible for the patient now. You are totally responsible for his hemodynamics. He will not be able to take care of his hemodynamics. You abort the test and you connect the ventilator back. If the apnea test is proceeding as planned and there is no respiratory effort in 8 to 10 minutes of disconnecting the ventilator, you check an ABG at the end of 10 minutes and you look for a PaCO2 rise. The PaCO2 rise that we are expecting is an absolute rise of more than 60 mm mercury or a rise of more than 20 millimeter mercury from the baseline. If these two are there, then an apnea test is positive and brain death is confirmed.
Revati, just can we go back to previous slide? I think this
Mhm.
slide is very, very important for the viewers. So understand that, can I explain a little bit here, Revati?
Yes. Yes, sir. Yes,
Uh,
yes.
so this, as Dr. Revati said before, that absolute rise of PCO2 should be more than 60. As she has already explained before that, means if you're suppose the rise should be more than 20 mm of Hg. So if we start from 35 mm of Hg and the rise is 20, means 55, then also apnea test will not be positive because the PCO2 has not crossed more than 60. This is very, very important. In a COPD patient, if you start by a baseline of 55, then if it crosses 65 or it becomes 65, then also apnea test is not positive because from 55, 20 should be the baseline elevation and it will go to 75. So both the things should be there. absolute rise should be more than 60 and the relative rise should be more than 20 mmHg. Is that correct, Revati?
Yes, yes, sir.
And one more thing I would like to ask, that suppose if we are not able to do apnea, we need to abort it somewhere in between. The patient become hemodynamically unstable after 2 3 minutes.
Yes,
So
sir.
what should we do? We connected
Hmm.
the patient to ventilator again. Then how to proceed from here?
So we connect the patient back to the ventilator. Sometimes what happens is it may be just the disconnection or the detachment of inotrope or vasopressor. If it is a small issue that can be addressed at that particular time, you can address it and try for apnea again. If you think you need some time for stabilizing the patient, you can stabilize and then retry for an apnea. Abort doesn't mean complete abort. You can stabilize and bring the patient back to normal parameters and retry.
But suppose if we are not able to do the apnea even on the second attempt, any way to proceed ahead from here?
Uh, yeah, you can change the way, if it is because of desaturation, then you can change the way you oxygenate in this case. So you, instead of using a tracheal insufflation catheter, you may use a high flow catheter if PEEP is the issue. If it is hemodynamic instability, that is the problem, then you find out the cause for hemodynamic instability and you treat that. Mostly it is DI. So in the presence of vasopressin, it should be, you should be able to.
Okay.
Otherwise, as a bridge, you can use ECMO also. So that is like a far alternative.
So what I wanted to ask that suppose we are not able to do the second apnea or first apnea because of hemodynamic stability, we are not able to perform.
Hmm.
So if you read the foreign guidelines or the guideline, they show that ancillary tests like four vessel angio or transcranial Doppler or these all things can be used. But as
Hmm.
of now, what we see in the Indian NATO guidelines, apnea test is mandatory per se. So
Mandatory. Yes,
ancillary
yes.
test can be supportive, and this decision can be taken in collaboration with your SOTO committee, which is a state.
Hmm.
That this is
Hmm.
the position and how do we do it. But there is no standard thing that without apnea we can proceed. We need to do apnea, and
Yes.
ancillary tests are ancillary. They are supporting evidence. But if the
Hmm.
case arises, then you need to coordinate with the SOTO and take permission. And this is a little bit more different way or procedure. I think
Yes, sir.
you need to
So
check
it
it.
is a little, it is a little tricky, and ancillary testing in India is doesn't have that much traction yet, even in the guidelines. So
Apnea
it
is must.
needs to be discussed with the local bodies. Yeah.
Okay. Okay.
So how do you interpret apnea test? As was told earlier, if you have a lab value rise of PaCO2 more than or equal to 60 mmHg, along with a rise of more than or equal to 20 mmHg from the baseline, both of them present, it means that the apnea test is successful and the patient is brain dead. Now, only one apnea test is not enough to certify the patient as brain dead. For the Form 10 to be completed and signed, you need two tests, 6 hours apart in an adult, and in children, it may be 12 to 24 hours apart. This is to rule out any other confounding effects, so that by the end of 6 hours, you can rule out all the confounders, all the other things that could potentially be mimicking as brain death. And at the end of 6 hours, you repeat the same procedure again. If brain death is still there, you, that is when if all the authorities sign and the patient is declared brain dead. So brain death is declared at the end of the second apnea test. Now, what are the common pitfalls and errors? Where do we usually misstep, and where does our apnea testing fail or brain death testing fail? Usually in the ICU, it is because of the presence of a residual drug effect, because we do not wait for 5 half-lives of the drug to have passed. The second most common cause is hypothermia, because hypothermia masquerades as coma. And if you do not bring the patient's temperature back to normal, the coma will not recover in some patients. The incomplete assessment of reflexes or skipping parts of brainstem check, gaps in documentation, and premature calling for the committee if the patient is stable. All these are the common pitfalls that we experience during our management of ICU patients, brain death. Now, after the first committee is done, there is 6 hours until the next committee comes. Can we just sit back and relax? Is there anything we need to do during these 6 hours? Is there anything that extra or anything that you can withdraw in these 6 hours because the apnea test is done. So the patient will take care of himself. Is that how it goes? Or will you counsel the relatives now? So we will address these points one by one. The most dangerous interval in the estimation of brain death is this 6 hour interval because there is a false sense of security in this 6 hour interval that the first apnea test is cleared, so the second will automatically get cleared. But the brain dead patient is very volatile because he has lost all control of the HPA axis and the hormones are not acting the way they should. So there is going to be dangerous ups and downs of volume status, of electrolytes, of sugars, of temperature. And all these need to be managed on an hourly, sometimes even minute by minute basis. So you can't rest in this 6 hour interval. The most of our brain death patients are lost because of hypotension, hypothermia, and electrolyte imbalance in these 6 hours. So once the apnea test is done and once the second committee is cleared, once the patient is declared brain dead, now the family is offered two options, two pathways which they can select. Now, Form 10 has been filled and the apnea test is completed, certification of brain death is completed. Now, the family can be asked whether they want to proceed with organ donation or not. The onus of responsibility lies with the family. If the family says, yes, we want to proceed, then you become a physiological guardian of the brain dead potential organ donor. If the family says, no, we don't want to proceed, then it transitions to compassionate withdrawal. So we will see these one by one. What is compassionate withdrawal? If the family has declined donation, then at this point, you need to communicate with the family compassionately alongside the coordinator, explain the process clearly, and simultaneously you can slowly withdraw the life support according to the SOTO policy or the hospital policy. All this while, you need to ensure dignity and proper documentation with a comprehensive death summary. If the second pathway is chosen by the family, which is that they want to proceed with organ donation, then you are no longer just the ICU physician. Your role now changes and you become the physiological guardian of the patient. Now, your ICU management will directly dictate how many number of organs are successfully retrieved and the long-term graft survival rate of these recipients. The main problems that we face in these patients are usually hormone and electrolyte disturbance because since the brain is dead, the pituitary, the hypothalamus are not able to communicate with the rest of the body. So the HPA axis is lost. So the influence of the pituitary and hypothalamus related hormones on the body are lost, which we see as most commonly as diabetes insipidus. So diabetes insipidus in these patients will present with severe dehydration with polyuria, and the patients will have increasing vasopressor requirement. It is important that we recognize this and treat it early because not treating diabetes insipidus early will cause severe hypovolemia, which can warrant impaired graft function. One. Second, it will increase the inotrope requirement, vasopressor requirement, which will further cause vasospasm in the arteries supplying all these end organs, and further it will damage the organs. So diabetes insipidus you need to identify and treat urgently. Second is dyselectrolytemia. The most common dyselectrolytemia that we see is secondary to diabetes insipidus, which is hypernatremia. Hypernatremia also you need to correct properly because high solute load to the kidney further impairs the function of the kidney, and then the graft function in the recipient is also impaired. Then the third problem that we see is thyroid and insulin related issues. So these patients might show a thyroid crash or hypoinsulinemia, which needs to be adjusted and treated. Now coming to the organ specific strategies that you need to adopt. When the lung needs to be harvested, what you will do to protect the lung is obviously a lung protective ventilation, which is a tidal volume of 6 to 8 ml per kg body weight. a PaO2 of 100 mmHg, targeting an SpO2 of more than 95%, and you will use gentle recruitment maneuvers and prevention of aspiration. This is what you will do for preserving the lungs. When it comes to kidneys, it is given that you have to avoid nephrotoxic drugs completely. You target a urine output of 1 to 3 ml per kg per hour. A urine output going higher than that should immediately raise suspicion of DI. Lower than that, you have to look out for any acute kidney injury. Now, some specific populations where brain death certification is, we need to understand how it works. So, ECMO. If a patient is on ECMO, how will you certify brain death in these patients? So, first and foremost, it is important to understand that ECMO is not a contraindication for organ donation, and ECMO may be relevant in organ donation in three scenarios. The first is as a bridge to brain death in severe hypoxic ischemic or cardiopulmonary failure. Second is when you want to stabilize the donor after brain death, especially if the heart is not too strong. If the heart is failing and you want the patient to survive until the retrieval, you can consider ECMO. And third is something called a normothermic regional perfusion, which is done after, in donation after cardiac death. So you maintain normothermia in the organs that need to be retrieved so that the function of those organs functions as it would in a live patient. Now, why would you need lung protective ventilation on ECMO? It is important to understand that ECMO itself is not a contraindication to lung transplant either. So, if the ECMO has been instituted because the heart was failing and the lung was actually fine, then you can consider lung retrieval also in these patients. When you are considering lung retrieval or lung transplant, the management strategy goes back to how you would manage in a non-ECMO patient. So, tidal volume of 6 to 8 ml per kg body weight with adequate PEEP, gentle recruitment, avoid atelectasis, and aspiration prevention. And the investigations you will include chest X-ray, bronchoscopy, and tracheal cultures, same as in a non-ECMO patient. Hemodynamic stability on ECMO, this is important to know because brain death itself is a huge hemodynamic burden. So it causes ups and downs in hemodynamics. In addition to that, when you add ECMO, then it further worsens the hemodynamic instability. So it is important to maintain hemodynamics on ECMO. It is important to know that if you can see good flow on ECMO, it doesn't mean that organ perfusion is good too. You have to rely on microcirculatory parameters like lactates for assessing the organ perfusion on ECMO. Even on ECMO, vasopressors are often required, and vasopressin may be instituted early because these patients have the chance of developing DI. It is important that we avoid hypotension because, similarly as on non-ECMO patients, these patients' hypotension can cause kidney failure and impairment of the liver graft. How do you proceed with apnea testing on ECMO? Everything else remains the same. The background remains the same. You prepare the patient the same way. You get the brainstem checks the same way. But what changes here is that you reduce the pause or sweep gas flow to a minimum to allow the PaCO2 to rise. And PaCO2 rise has to be the same, at least 60 mmHg or along with that 20 mmHg from the baseline. When both of them are present, then the apnea test is successful. And if the patient goes unstable, then you have to abort and think of ancillary tests. Organ specific management on ECMO. Again, when you come to kidney, you have to make sure that you avoid all nephrotoxic drugs, maintain adequate perfusion. For the liver, you have to correct all acidosis and coagulopathy. When heart is being considered, we need a serial trend of all the enzymes, so TROPS and BNP, along with echo. We'll need to do this serially, and video and photo documentation is necessary. For lungs, again to reiterate, ECMO is not an exclusion and we need lung protective maneuvers. Coming to the ethical conundrum, some patients may be dicey whether you need to evaluate them or whether you don't consider them for brain death. So when you think about the infected donor, when a patient comes to you infected in septic shock or in sepsis, and you know that the patient is septic, would you consider the organs from that patient for transplant? So In this case, what will happen is you will collect samples as soon as the patient presents to you. The transplant team will obtain all the culture reports as soon as possible and carry the donor samples for repeat cultures as well. Now, the risk of this infection transmission will be discussed with the recipient's family also and with the ZTCC also, so the zonal transplant coordination team. And the infection will then be categorized as either unacceptable, where the donor won't be considered at all, increased but acceptable, where only a few select organs will be considered, calculated, non-assessable, or standard risk. What about the seropositive donor? What if you are evaluating a patient for brain death or for organ donation and the patient incidentally turns out to be HIV positive? Will you then not evaluate for organ donation? According to the state policy, sometimes an HIV positive donor can donate to an HIV positive recipient. However, this is again very strictly adherent to the state policy guidelines. Coming to COVID-19 and TB infection, for rare infections, the patient may not be screened regularly, but for high-risk infections, it is important that you screen on a risk-benefit basis. Tuberculosis is not an absolute contraindication, but inadequately treated MDR-TB is a relative contraindication for donation. For COVID-19, it is important to follow the standard operating procedure that is being employed at the state level. COVID-19 PCR report is mandatory when a lung transplant is being considered. Coming to poisoning, snakebite, and trauma. So, when you have an organophosphorus poisoning or an organochloride poisoning donor, for example, these can still be considered suitable for donation provided 5 half-lives of the organophosphorus or organochloride compound has passed and it has left no residual effect on the organs. Snakebite again is on an organ specific and case by case basis depending on the degree of hemolysis, DIC, or ATN that can be seen. For donors with thoracic or abdominal trauma, you have to again be careful about the assessment of extent of injury before you accept the organ. Now, this is one conundrum which may not be very common because it is not known commonly. But if you come across this, if you come across a donor with a tumor, will you consider, will you reject? How will you go about? So, ISCCM statement, also TOA TOTA, they have given an entire list of tumors that can be accepted, which are absolutely contraindicated, which have a high risk of transmission, intermediate or low risk of transmission. So we need to know that a primary CNS lymphoma and all secondary intracranial tumors, all METs into the brain, are absolutely contraindicated. But along with that, we also need to know that few tumors, like a basal cell carcinoma of the skin or a squamous cell carcinoma of the skin without METs, few of these, like a cervical carcinoma, localized tumors, these patients can be taken up with a minimal risk of transmission. So this is the Form 10. This is the certification of brainstem death form, which needs to be signed by the certifying authorities, which were the four that we discussed earlier: the intensivist, the RMP, the clinician in charge, the neurosurgeon. All these people will certify 6 hours apart, two signatures. Only after this will the patient be declared brain dead. After this, a Form 8 is a declaration cum consent which is signed by the next of kin of the patient. After this Form 8 is signed is when the patient will be evaluated for donation, for the organ donation. So, in a nutshell, as an intensivist, first, how will you identify brain death or how will you suspect brain death is a GCS of 3 in the background of catastrophic brain injury while excluding all confounders. Once you have all these three together, then you go ahead and do a brain stem check. So all the 7 reflexes, pupillary, conjunctival, corneal, cuff, gag, oculocephalic, oculovestibular, and the motor reflexes. Once those are all negative, then you inform the chain of command, your ICU in charge, medical superintendent, zonal transplant organization, and then a panel is put forth. The panel will come ahead for the Form 10 certification. They will do apnea test twice, 6 hours apart. Apnea test endpoint is 60 mmHg rise of PCO2 and a rise of 20 mmHg from the baseline. If these two are present, apnea test is positive. 6 hours later, again present, again positive. That is when the brainstem death is declared and signed. After this, the patient is evaluated for the organs that need to be retrieved and the organ specific management starts. The general management that we take care of includes management for DI, management for thyroid issues, and for insulin related issues, hyper and hypoglycemia, and the organ specific management, lung protection for lung. The audio, video and camera documentation for of echo for heart, all those things for the organ specific management. So this is in a nutshell of what and the conundrums that we discussed. Now we come to the checklist. This is a comprehensive checklist that, as an intensivist, will take you through all the things that you need to know and all the things that you need to cover, all the bases that you need to cover in a suspected brain dead patient to the brain dead declared patient to the potential organ donor. So let me just play this for you. So this is when the pre-apnea test is happening. So you look at the patient with a GCS of less than 3, core temperature, all these confounders, you remove them, and then you look for the brainstem reflexes testing. Once all of this is done, once all of this is checked out, these boxes, then you go for the apnea test. Once the apnea test is done, you do a post-apnea assessment. Make sure that all the samples that are required to be collected and dispatched are done timely. These should include the cultures for sure. Then you go ahead and do the organ specific management, which for kidney includes urine, serum, creatinine, urine culture, USG abdomen, and HTLV1 or a renal biopsy. Liver function tests for the liver, again ultrasound. For the heart, an echo and documentation of the echo. For the lung, a bronchoscopy and COVID-19. For pancreas, serum amylase lipase. And this is the post apnea management. So that is in a nutshell of how we will proceed. What is the checklist that we will follow in a patient of brain death, suspected brain death, and when you proceed with organ donation, how do you go about it?
Thank you, Dr. Revathi. Uh, it was really a very, I would say, simplified as well as a comprehensive section. So I didn't interrupt it later on during the session because your flow was so nice that I didn't wanted to stop you in between. Now, can you stop sharing this presentation so that we can have a little bit of doubts which I have, I can ask you?
Yes.
So I have a few doubts which I think the viewers may also feel at times. Can you mm, have a little bit of information about the Lazara's reflex while the brainstem testing? That what is it, what it is, and why it happens, and it should not be considered as sign of the brainstem function. Lazara's reflex.
Hmm. So Lazarus reflex is a local spinal cord arc that is getting stimulated in response to your stimulus. So it is not the brain, like the nerve carrying the impulse to the brain and then bringing the response back. It is a local spinal cord arc. So it usually presents as a triple flexion response. So whichever limb has been stimulated, that limb at 3 joints, it will show 3 flexions. So this is most commonly seen in children because they have immature nervous system and the myelination is improper or incomplete. So this should not be mistaken for signs of cerebral activity or cortical activity, and this will most probably be abolished with time. So we can either wait it out, or if the state policy allows us, or if the team as a total decides on going forward, proceeding, then we can proceed with the testing.
Okay, so one more thing regarding this is we should inform the family members regarding this, that this could happen if you touch at the patient leg or something like that. It may happen that the patient may flex the leg or the hand. It is not that the patient is alive or something like that, it is a sign of the spinal cord. This needs to be explained to every attendant, I think, because in a rare case, it can create a confusion at the last
Yes.
minute. Second thing which I would like to ask is, what would be the legal time of death as per that? So we have done first apnea and then we have done a second apnea. So second
Hmm.
apnea, we have declared that the patient is brain dead. Now the
Hmm.
family wants the key, they will go ahead with organ donations, and in the OT, when the organs will be retrieved, obviously there will be cardiac arrest. So what will be
Yeah.
the legal time of death of this patient?
Legal time of death will be at the end of the second apnea test when the committee has certified that the patient is brain dead and signed the form 10. That will be the time of the legal death.
Yes, so this is very, very important, because just because we have declared by way of the brain dead, actually the patient is dead at that moment. So cardiac death and brain death, there are two things. As of now, on the certification, there is only cardiac death is there, there, but there is, I think, sooner or later, there in the form, the type of mode of death will also be there, which will be either a cardiac death or a neurological death sort of thing. So second apnea is the time of death. Now,
Yes.
regarding the organ management, I would like to ask that for thyroid, the guidelines say that IV thyroxine should be given. So, in
Hmm.
Indian case scenario, where if it is not available, how do we proceed in that?
So we have usually faced this issue that there is a thyroid crash, and we usually proceed with giving tablet thyroxine through the Riles tube. That
Any
usually suffices.
any dose which you would like to recommend or advise?
50 micrograms OD is what we usually use in our practice.
Okay. Okay. Now, two three questions also I would like to ask that what is the vasopressors of choice if the support the patient is becoming hemodynamically unstable and need to take a support, so it's still an noradrenaline or some other choice we need to take?
So, sir, we need to know what is the reason for the hemodynamic instability. In these patients, the most common reason is a diabetes insipidus. So, if it is diabetes insipidus, no matter how much you increase your noradrenaline, it is not going to improve. You will need vasopressin to support it. On the other hand, some of them might have Takotsubo cardiomyopathy or a stress-induced cardiomyopathy. In that case, maybe noradrenaline. Some patients might need dobutamine for a short while. So you need to know what is the cause of hemodynamic instability. Yes, NORAD will be the most common choice, but for this context, it is most usually used will be vasopressin.
Okay. Now, one more thing that um, during apnea testing, if there is a cervical cord injury or tympanic membrane is ruptured, so we can't do the that Doll's-Eye movement test, or we can't do the cold calorie test. So it is okay with if we can skip this and do the other sign, look for other signs of brainstem function.
Yes, sir. It is okay if you skip them because you don't need to do all of them. You can skip one over the other
Most
and
importantly,
proceed with the rest.
most importantly, if there is no gag reflex, I think it is the
Gag
lowest sign
reflex, you can.
which
Yes.
is there. And regarding this mandatory test, so CAG for all patients more than 40 years of age is a mandate, or only in cardiac transplant we need to check?
In cardiac transplant, CAG in patients more than 40 years of age, or if there is any sign of visible cardiac dysfunction, then a CAG may be required.
And bronchoscopy is mandatory in every patient?
Bronchoscopy when lung transplant is planned is mandatory.
Okay. Then one more question is withdrawing the life support. Suppose after the second apnea, we have declared the patient brain dead. So technically, patient is dead. So if the family says that we don't want to continue the treatment further, so we can withdraw the ventilator, or no, we need to continue the ventilator till the cardiac death occurs.
No, so this is sort of a gray zone, but then it again goes to state-wise policy. Like Kerala has now delinked the two things, so it is allowed that you withdraw the ventilator. So Kerala has recently delinked the brain death certification process from the organ donation process. So you can use the brain death certification to certify that the patient is clinically dead, even if you don't want to proceed with organ donation. If that is the case, then you can go ahead and withdraw the ventilator support slowly. So it is a state-wise policy. Uh, it is not a one rule fits all.
One last question before I ask you for the any personal experience. Now, suppose a patient has suffered a cardiac arrest, and now we post CPR status. If the patient is in a post CPR status, and then for any reason the patient is now showing no signs of brainstem function, so post CPR patients can also be taken for brain dead, or post CPR we can't do that.
No, nothing like that. Post CPR patients can also be taken, provided they fulfill all the criteria that was mentioned earlier. They are not a contraindication.
Okay. So these were the questions from my side on behalf of the viewers who are watching this meeting and channel. Any personal experience or tips you would like to share with the students or the viewers who are listening this session?
Yeah, so personal experience, sir, most of the time what we face is our patients are usually traumatic brain injury patients, and they are terminal, like they're escalating care of high ICP checklist, right? So we are already putting them on barbiturate coma towards the end of when everything has failed, they are on barbiturate coma. And when we realize that that is also not working is when we start evaluating for potential brain death. So we need time to wash out the barbiturate coma, and we have seen that that 48-hour window, even though it looks enough, it might not be enough if the patient has been hypothermic also, along with being in barbiturate coma. So we need to actually take care of that as well, and we heavily rely on TCD, the ONSD findings to be very sure. That is one. Second, with pediatric organ donors, we have faced many a times this triple flexion response, this Lazarus phenomenon, and patient's family does not come to terms with the fact that the patient is brain dead when they actually see the hands and legs moving. So it takes a lot of time to comfort them, to counsel them, to bring them to terms with it. So when they are not at terms with it, it is better that you first focus all your attention on counseling them and bringing them up to date to what the condition of the patient is, and then proceed. And then mostly these patients have very weird hemodynamics, sudden changes in hemodynamics, which become difficult to manage if you have not done 2 hourly, 4 hourly ABGs. So it is very important that we continuously monitor the hemodynamics also, blood gas also, the temperature also, sugars also. So these patients won't let you rest, and it is better that way because they need a lot of continuous monitoring. It also improves the survival of a lot of other patients when you do it properly here.
One more thing which I would like to ask you and tell the viewers. Suppose it happens that suppose the family has given consent for the organ donation, everything is planned, the OT is ready, and now the even the patient is on the verge of getting shifted to OT or getting shifted, and suddenly some relatives come and they stop it. No, we don't want to donate the organs. Have you faced this situation, or what does the guideline say? What you should do at this stage?
So we have not faced this situation, but the guideline is very clear that if there is a no at any point, even after certification, even after consent, then you abort. You don't proceed with the donation. The guidelines are very clear about
Even they say that if the patient has reached the OT and if they say that we don't want to go ahead, we can stop there. So the message should be very clear that brain dead is what we are declaring is that we are prognosticating the patient that there is no chance of recovery. It's a irreversible damage. The patient is dead. Whether they want to go for organ donation or not, it's a very separate issue which is unrelated to that. But that's the window we get where we can get the organs. So thank you, Dr. Revathi. And any message or your tips or anything would you like to tell about the ICU channel and ESB ICM to our viewers? Your thoughts on this? And how did you
it.
feel like coming to ESB ICM?
You are doing a wonderful job, sir. First of all, I should congratulate you for that. A lot of intensivists are learning and getting to interact with many other intensivists through you. So you have become a medium for that too. Um, so how I came across ESBICM is the channel is pretty famous, so it's hard to miss the channel. If you open Instagram or you open YouTube, it is just there. That's how famous it has become. Uh, Very nice, sir. Very concise the way you address the topics or the questions that people throw at you. It's very easy to understand for novices also, for advanced learners also.
So
Thank you, sir.
anything, any suggestion which you like to give to the this online platform of the ESBICM, the ICU channel, which we should include in future on the channel? Anything you felt
Uh,
missing or which should be there?
Missing तो नहीं. We would like to see you bring out a few books, tips and tricks for maybe novices, or tips and tricks of how to manage the ICU, the main issues that we face in the ICU. Not just the theories, but the issues, actual issues.
Okay, so we'll think on that. And just because you are here, I would like to tell our viewers, those who are viewing, that very soon we are opening the critical care faculty network on the ICU channel and ESBICM as a part of the ESBICM expanding faculty network. So once the form is released, you can apply, and there will be three-tier faculty. One is research faculty, other is the educator faculty, and third is the next gen faculty. And anybody can apply for, if they want, if they have a good topic which they want a platform to share with the audience, they can always write a mail to us on academics@esbicm.org. We'll put the details in the description. And Dr. Revathi, we are very lucky to have you. I think we have found a gem of teacher for our future faculty on ESBICM. We would love to join you as a critical care faculty on network. As soon as it opens, we'll share the link with you. We'd love to have you on board.
Pleasure is all mine, sir. Thank you.
Thank you.
Thank
With
you.
that, so we'll see you soon in the next session. Thank you.